Okay. Good evening, everyone. Can I ask people to take their seats? For those who read these things closely, you may notice we have a few speakers tonight. So the sooner we get started, the sooner we can go upstairs to a reception. That's my incentive to all of you. Thank you so much for being here. My name is Mitchell Warren. Well, I'll wait for a little. It's okay? I don't know if people. Lloyd, can you hear me? Lloyd can hear me.
Yes, I can.
Okay. If Prof. Mulinga can hear me, we're in good shape. Good evening, everybody. Good evening. I was filling time for you. Hello, my sister. Welcome, everybody. My name is Mitchell Warren. I direct AVAC, an organization focused on HIV prevention. And I also have the great pleasure with my friend and colleague, Nduku Kalanza, to be one of the two co-chairs of the Global Prevention Coalition. And it's under the auspices of the Global Prevention Coalition, along with UNAIDS and UNFPA and UNDP and WHO, as well as the governments of the Federal Republic of Brazil and the Kingdom of the Netherlands. They're hugging. You can see we have strong partnership and leadership. We can. Welcome. I'm delighted to have representatives from so many countries and organizations who I believe walked into this room, I hope walked into this room with a deep and abiding commitment to prevention. If you didn't, we will ensure that 2 hours from now, as you leave to go upstairs to a reception, that you are even more committed to a shared passion for HIV prevention. There are many issues in the HIV response. There are many issues in global health, many issues in global development right now, sitting here on May 20th of 2025, that I needn't tell all of you why this meeting is so important. Every aspect of our work that is in this room, named for Kofi Annan, named around multilateralism, named around collaboration, named around countries and communities coming together. That's what this room stands for. That's what UNAIDS stands for. And I'm thrilled, along with Nduku, to be here to welcome you. And it's at one of the most exciting times in 44 years of the HIV response. And I am prone, perhaps because I'm an advocate, people say I sometimes exaggerate, but I really do believe in 44 years, this is one of our greatest opportunities in HIV prevention. And yet it comes at the most challenging moment in global solidarity and in the AIDS response. And so tonight, we really need together to understand how we leave this room in a collaborative way, in a deeply co-committed way, to making sure that we do not squander another opportunity. And we have to do it, as I said, in a most challenging time. I should say, from a logistical point of view, there is simultaneous translation in multiple languages: French, Spanish, Portuguese, Russian, and Chinese. And it's all in the little devices here. So please do make yourself at home there. Again, I want to thank you all for being here. And I want to first, we have a number of speakers. We are going to keep to time. You know, we have ambitious targets in the AIDS response. We're going to end this epidemic by 2030. We're also going to keep everybody to a few minutes of remarks. I'm not sure which of those is a more ambitious target, but we're going to try. But I first want to welcome and thank Winnie Byanyima, the Executive Director of UNAIDS. And although the Global Prevention Coalition has many, as they say, success has many parents, failure is an orphan. But Winnie, your leadership of UNAIDS and your support, along with UNFPA, of the GPC is so important to all of us. And I'm delighted to turn it over to you, and it's your house. So please.
Thank you, Mitch. And welcome your friends to Kofi Annan Room at UNAIDS. You're all welcome. I feel good and encouraged to see the room is full. Thank you. I want to start by addressing the elephant in the room. The global HIV response is disrupted, seriously disrupted. Let's face it. Global solidarity is waning. External assistance to developing countries that have need is being pulled away abruptly. If we continue down this path, UNAIDS is estimating that we could see an additional 6 million new infections by 2029, 4 years' time. 4 million more AIDS-related deaths by 2029. This is serious disruption. We will lose, the truth is we will lose control of the AIDS epidemic. We are at a moment that we haven't been at in the last, let's say, 25 years. I'm old enough to remember those dark days of this pandemic when in my country, the most lucrative business was that of making coffins, and they lined the roads. I do not want us to go back there, but we could. But we have an opportunity. We really do have an opportunity today. I see it and I've been talking about it. We have the new long-acting HIV prevention tools. These could reshape the HIV response. They could help us to ambitiously drive down new infections to a point where we are back on the right path. And in this room here, we have many of the people whom we need to make it happen. Gilead Sciences, Eva Pharma, producers of these game-changing medicines are here. Donor governments who can help roll this out, shape the market are here. Developing countries who themselves are ambitiously paying for their own responses. And also emerging economies that have huge capacity for production, generic production, they are here. And then we also have the communities represented here. The communities who know how to reach that last person who needs a prevention tool. So if we can take a moonshot approach to scale up long-acting injectables, make them affordable to everyone who needs them in every country, including middle-income countries, we could make it. If we could make full use of the whole prevention toolkit alongside the long-acting injectables. I'm talking about education for girls, sexuality education in schools, harm reduction programs, condoms and PrEP, if we keep that going as well. If we scale up domestic investment in HIV in every country, but of course, working with the donor governments for a gradual transition to full ownership, not abrupt taking away of resources. Rich country governments, if you don't walk away, then we can stay on course and not lose the gains. It is possible. It is possible. These long-acting injectables, we could roll them out very fast. Remember, we saw it at the turn of the century, the millennium. Yeah, it was the end of that century, when governments came together and set up us, UNAIDS, set up the Global Fund, set up PEPFAR, set up UNITAID, and then we saw the rolling out of ARVs. We are here today because of those important decisions that were made then. We saw it again during COVID. Although many things didn't go right, but we did see 4 billion people getting a COVID vaccine in 1 year. If 4 billion people can get a vaccine in 1 year, what about rolling out long-acting injectables? We can do it. We can have our one shot to end AIDS. So I want to finish with 2 questions to all of us. What will we do to help seize this moment? This is my question to our panelists here. What can UNAIDS do to help get us there? Let's answer those questions. Thank you.
Winnie, thank you so much for setting the tone and reminding us of the urgency. Time is not on our side. And I think the question, how do we translate the possible into the probable, and to make it so? As I think your predecessor, Peter Piot, once said, there's no one in the AIDS response. And the Global Prevention Coalition is co-convened by UNAIDS and UNFPA. And I'm delighted to turn to my left to the relatively new Chief of Sexual and Reproductive Health Branch of UNFPA, Ayman Mohsen, to provide a perspective, because it isn't just about an AIDS response, it's about a comprehensive sexual reproductive health response.
Thank you very much, Mitchell, and good evening, everyone. I would like to start by sending the regards of our Executive Director, Dr. Natalia Kanem, who apologizes for not being able to join WHA this year due to other commitments. And I would also like to thank the co-chairs and Madam Executive Director of UNAIDS for the very nice and inspiring words that you've mentioned. And we hope we will be able to jointly answer your 2 very good questions, Madam. Honorable Ministers, Excellencies, colleagues, and friends, we are at a defining moment in the global HIV response. After decades of progress, we now face a dangerous backslide. The commitment to treatment has remained relatively steady, but prevention, particularly HIV prevention, risks being left behind. And yet, there are tremendous opportunities before us. We know that strengthening health systems with a primary healthcare focus and integrating HIV prevention into broader sexual and reproductive health and rights frameworks can significantly expand access and impact. UNFPA has championed these approaches for decades, but let's be clear, integration alone cannot dismantle the structural barriers, stigma, discrimination, gender inequality that still block access for adolescent girls, young women, and key populations. To overcome these barriers, we must empower communities, and we must ensure access to the next generation of prevention tools, technologies that place more control directly into people's hands. This is why UNFPA strongly believes that long-acting HIV prevention tools and technologies represent one of the most consequential opportunities of our time. These innovations are not aspirational, they are essential. Imagine a safe, discreet medicine that is nearly 100% effective in preventing HIV. That medicine exists, and if I may quote Madam Executive Director, and rolling it out is a possibility, and it's a mandate. The question is not whether we can afford to offer it in low resource settings, but whether we can afford not to. Yes, fiscal constraints are real. Yes, health systems are under strain, but we've been here before. We saw this with nevirapine after the HIV-NET 012 trial in Uganda, a proven tool to prevent mother-to-child transmission, delayed for years, not because of science, but because of politics. We must not repeat that history. The family planning community has shown us that with global solidarity, pooled procurement, and a strong political will, high-cost innovation like contraceptive implants can overcome widely accessible even in low-income countries. And just as with family planning, choice must remain central. Long-acting HIV prevention tools must expand, not replace, the range of options available. These tools are not optional add-ons. They are central to advancing the SDGs, delivering on our SRHR mandate, and fulfilling our pledge to leave no one behind. They are especially critical for those our systems routinely fail, those facing stigma, criminalization, or exclusion. Let me be clear, introducing innovation during a crisis is not reckless. It is responsible. It signals our commitment to equity, dignity, and health for all. It's not a question of if, it's a question of how fast. We must and we will accelerate access to long-acting HIV prevention technology. And I thank you.
Simon, thank you, and UNFPA. We're going to transition into a relatively rapid-fire panel representing a number of country perspectives. I do want to highlight just at your seats or at the table, you'll find a new mini brief from the Global Prevention Coalition, really looking at about the issues that Winnie raised about how to seize the opportunity. And I just want to highlight the graphic at the bottom that has a bit of a color chart, red, blue, and green. Blue already represents where we were, which was good, but not great. Green represents the ambition that Ayman described and how we need to go faster together to actually drive incidents down. But sadly, we now have, beginning in January of 2025, that red line, which shows what happens if we don't even hold steady to where we were. And those become, and I think as Ayman said, this is not just about the science of prevention and of HIV. This is about the political choices that each of us make, country level, community level, and everywhere in between. With that, I want to turn to the panel. We will keep it to 3 minutes, please, for each of the panelists. I'm delighted that we're going to start not only with the current vice chair of the program coordinating board of UNAIDS and a co-sponsor of tonight's event, the government of Brazil, but also an alum of the UNAIDS program. I first interacted with Mariangela Simão when she was sitting in UNAIDS, and it was under her tenure when the Global Prevention Coalition was actually created. So welcome home, welcome back. And it's great because Brazil has been for decades a pioneer in innovation, and delighted to turn the table to you.
Thank you. And let me say it's a pleasure to be in the Kofi Annan room. It's the second time I'm here during this assembly, but it's always a pleasure to be here. And it's a pleasure to be in a UNAIDS event. And let me say that first, that one of the things that Brazil is not being affected by these cuts, because there was always a strong leadership. And I'd like to say that I'm accompanied here by the former Minister of Health, Mr. Nizia, who was a strong advocate for prevention in Brazil. And we also have a minister now, Dr. Padilla, who went on Instagram during Lady Gaga. Lady Gaga was in Brazil, and in the day she was in Brazil, he was doing the concert. He went on Instagram and invited men who use PrEP to go for hepatitis A vaccination. So we have a history of strong political leadership, and I am very proud of it. And then treatment is not a problem in Brazil because it's protected legally. But then your question about what is UNAIDS added value, and it wasn't phrased like that, it was more elegant, right? But no, let me say that PrEP in Brazil is now a reality. And when this government, President Lula's tenure started and Minister Nizia was the Minister of Health, we had a target of reaching 50,000 people with PrEP by 2025. And actually, we do have 122,000 active right now. There's 60,000 inactive, but we have 122,000 people using PrEP right now in Brazil. And we have a target of reaching 300,000 by the end of next year. Of course, there's a challenge because it's like 82% are men, gay men, and most are white men, middle class, right? So we still have a challenge to reach the most vulnerable gay men. But where I think UNAIDS can help, and where I think we do have data showing the incidence is falling. After we started rolling up in cities of more than 100,000 people, inhabitants, with higher coverage, we are showing incidence falling, and this is what we need to show, because it's not smart to stop now. It's not smart. So we are, of course, very interested in implementing the long-acting technologies, but we're not there yet, because first we do need the registration with the Anvisa, which is the National Regulatory Authority. But we have on our plans cabotegravir and lenacapavir. But it's not only pending on the registration, it's also pending on the price negotiations, because access to prevention in Brazil is a right as access to health, and the government has to provide the means for people to access. And this means that we have a limited budget, right? So we do need to make this budget work for preventing new infections. So at the end, and we are doing the public-private partnership, we are calling development partnership. But at the end of the day, this has to result in an affordable price for the government that allows us to scale up the coverage. And to end, I've been citing a lot during this assembly, but it's important because it's a Frelimo. A luta continua, which means the fight goes on. Fight goes on, it's not over yet. And it was added later, a luta continua e a vitória certa, and victory is certain. But I don't think victory is certain. Victory is uncertain. That's why we need to keep on with the fight, and we need UNAIDS with us. Thank you.
Thank you. Victory is possible, not certain, and we need to move to certainty. And we're going to move from Brazil to Zimbabwe, just going across the southern part of the world, and delighted to welcome the Minister of Health of Zimbabwe, the Honorable Douglas Mambashora. And Zimbabwe, as many of you will know, has really been, along with its neighbors, Zambia and South Africa, really pioneers in PrEP programming over the last several years. And delighted to welcome you, Honorable Minister.
Thank you very much, distinguished guests. I'm going to talk about how Zimbabwe is sustaining reduction in new HIV acquisitions in the current environment, and what will be the role of long-acting HIV prevention methods in sustaining reductions in new HIV infections in Zimbabwe. I can say Zimbabwe is making significant strides in reducing new HIV infection, and thanks to a combination of effective strategies and interventions. Some notable statistics highlighting Zimbabwe's progress include: 1, reduction in new HIV infections. New HIV infections declined from 40,900 in 2016 to 24,900 in 2020, representing a significant decrease. 2, achievement of 95 targets. Zimbabwe has successfully achieved the UNAIDS fast-track targets for adults, with 97% of people living with HIV knowing their status, 99% of those diagnosed receiving treatment, and 96% of those on treatment achieving viral load suppression. 3, reductions in new HIV infections among adolescent girls and young women, with a decline of at least 65% between 2010 and 2022. The introduction of long-acting HIV prevention methods is expected to further accelerate this progress, particularly when combined with other prevention approaches. I'll just mention key success factors contributing to this progress, and these include: 1, increased coverage of combination prevention programs. Zimbabwe has expanded its coverage of combination prevention programs, including antiretroviral-based prevention, targeted primary prevention programs, and behavioral interventions. This approach has been particularly effective in reducing new HIV infections among adolescent girls and young women. 2, improved access to HIV services. The country has made significant progress in increasing access to HIV testing, treatment, and care services. This includes the rollout of differentiated service delivery models, which provided tailored HIV prevention, testing, and treatment options. 3, innovative prevention methods. Zimbabwe has introduced new HIV prevention methods such as the cabotegravir injection, which provides a long-acting injectable prevention option for people at high risk of HIV. 4, enhanced treatment adherence. The country has also improved treatment adherence, particularly among children living with HIV, through the rollout of child-friendly dolutegravir-based pediatric medicines and fixed-dose combination therapies. 5, integration of people-centered service delivery. We have integrated family planning services, sexually transmitted infections testing and treatment, and HIV prevention and treatment at health facilities, making it easier for individuals to access comprehensive care. And 6, community engagement and education. The country has emphasized the importance of community engagement, education, and stigma reduction in its HIV response, recognizing that these efforts are critical to achieving an AIDS-free generation. Long-acting HIV prevention methods are expected to play a significant role in sustaining reductions in new HIV infections, particularly among high-risk populations such as adolescent girls and young women. These methods offer several advantages over traditional daily oral pre-exposure prophylaxis, and these advantages include improved adherence, increased effectiveness, discreet and convenient. Long-acting methods can be administered via injection or implant, providing a discreet and convenient option for individuals who may struggle with daily pill taking. To maximize impact, in order to maximize impact, the impact of long-acting HIV prevention methods, the country will need to finalize strategies for introducing long-acting methods into existing HIV prevention programs. This will include building the capacity to ensure healthcare providers are trained to administer long-acting methods. The country will also need to strengthen its monitoring and evaluation system to track the effectiveness and safety of long-acting methods in real-world settings. Overall, Zimbabwe's sustained efforts to reduce new HIV infections demonstrate the effectiveness of its comprehensive approach to HIV prevention, treatment, and care, including long-acting injectables. I thank you.
Great, Mr. Minister, thank you so much. He got 30 extra seconds because he talked about the importance of community engagement. And when a minister of health talks about the importance of community, they get 30 extra seconds, but no one else does. But we're going to now turn to a neighbor of Zimbabwe. We're going to move to Mozambique, to the Honorable Minister of Health there, Dr. Iseni Hilario Isse. Mozambique, as many of you will know, has the second largest number of new infections in the region. And so prevention is particularly critical that we get ahead of it. So, Mr. Minister.
Muito obrigado pela palavra. Senhora Diretora Executiva da UNAIDS, estimados ministros, I'll speak in my mother tongue, please use the thank you. May I go ahead?
Yes, please.
Thank you. Saúde a todos os presentes. Moçambique está num momento crítico na resposta ao HIV. Moçambique, maior número de novas infecções por HIV no mundo e ocupa a terceira posição global em número de pessoas vivendo com HIV/SIDA. Em 2015, registramos cerca de 150 mil novas infecções e agora, em 2024, 92 mil novas infecções. Significa que reduzimos significativamente, mas ainda continuamos com um índice muito elevado de novas infecções. Temos, neste momento, no país, cerca de 200 mil em profilaxia pré-exposição. Apesar de anos de esforço colaborativo e de avanços significativos na cobertura de tratamento antirretroviral, o número de novas infecções continua alto e inaceitável, especialmente entre raparigas, adolescentes, mulheres jovens, mulheres grávidas, lactentes e crianças. É fundamental ampliar os esforços e opções de prevenção primária para reduzir o número de novas infecções e aliviar a carga sobre os serviços de cuidados e tratamento. É imprescindível investir de forma integrada e sustentável na prevenção, adotando abordagens inovadoras, como a profilaxia pré-exposição injetável e centradas nas pessoas, incluindo aquelas lideradas pelas comunidades. Moçambique está a avançar no bom caminho para a introdução da profilaxia pré-exposição injetável. Estas novas tecnologias de prevenção devem ser utilizadas conjuntamente com as já existentes, se queremos evitar não só a propagação do HIV, mas também da sífilis, da hepatite B e outras infecções sexualmente transmitidas que têm estado a aumentar no meio da nossa população moçambicana. A decisão do governo dos Estados Unidos de reduzir o financiamento para a prevenção do HIV representa um retrocesso grave, com implicações imediatas, nomeadamente milhares de raparigas, adolescentes e mulheres jovens, população-chave e comunidades vulneráveis, perderam o acesso a serviços essenciais como a profilaxia pré-exposição, preservativos, autoteste de HIV e circuncisão masculina médica e voluntária. Isso enfraquece os pilares fundamentais da prevenção combinada, colocando vidas em risco e aumentando os encargos futuros com o tratamento. Estes cortes ocorrem no momento em que a prevenção deveria ser ampliada, não reduzida. Essa é também uma oportunidade para acelerar os esforços do país rumo ao financiamento sustentável com mobilização de financiamento doméstico. A prevenção é custo eficaz, uma vez que cada infecção evitada representa um avanço na interrupção da cadeia de transmissão e ganhos na redução de custos com o tratamento antirretroviral, monitoria da carga viral e outros custos com cuidados de saúde. É hora de mudarmos o foco de tratar a epidemia para interrompê-la na origem, pois é mais caro tratar do que prevenir. A integração da prevenção da HIV nos cuidados primários de saúde é crítica para assegurar a sustentabilidade da resposta. A agenda de prevenção deve ser centrada na pessoa e liderada pelas comunidades. A resposta nacional em Moçambique tem um financiamento significativo de parceiros internacionais. É neste sentido que embarcamos na elaboração de um roteiro de sustentabilidade de financiamento da resposta ao HIV, com marcos, custos e mecanismos de responsabilização partilhada, explorando modelos inovadores de financiamento da saúde. A prevenção não é opção, é urgente. Não podemos permitir que mudanças pontuais no financiamento revertam anos de progresso. O futuro da resposta ao HIV em Moçambique depende da nossa capacidade de prevenir novas infecções, empoderar as comunidades e construir um sistema que o país possa liderar e sustentar. Apelamos a todos os parceiros para que apoiem uma agenda de prevenção renovada, centrada na pessoa e sustentável, antes que mais vidas sejam perdidas e os avanços conquistados sejam comprometidos. Muito obrigado pela atenção dispensada.
Obrigado, Mr. Minister. Thank you so much. That was a remarkable call to action, and it reminds us that the sustainability agendas that countries are working on have to have prevention at their center. Prevention is the sustainability agenda so that we can maintain people on treatment. With that, we do want to shift into some financial conversation because, of course, nothing in life is free. And we are delighted that we're joined by the Global Fund in the room, and particularly in this case by Michael Byrne, the head of the Technical Advice and Partnerships Program within the Global Fund. And the Global Fund, under Peter Sands' leadership, has really been a pioneer in thinking about the innovation of long-acting PrEP. And as many of you will know, in December, PEPFAR and the Global Fund announced an ambitious commitment to scale up the newest injectable that you'll hear about. And I'm very pleased to know that the Global Fund remains committed to that ambition. So please, Michael.
Thanks, Mitch, Dr. Winnie, distinguished guests, everybody. Fantastic to be here because this is to voice and action our unwavering commitment to HIV prevention. It's central to our mission to end HIV. And your work, particularly at country level, has already led to a substantial increase in the Global Fund investments in HIV prevention, in high impact interventions like PrEP, like condoms, like harm reduction for key populations, but also for adolescent girls and young women, especially in East and Southern Africa. I'm looking particularly at my colleagues in Zimbabwe and Mozambique. And the Global Fund doesn't just invest in commodities, we also invest to strengthen with countries their systems and integration, like data systems for local decision-making, supply chain and community workers, which are all the foundations for sustainable prevention programs. And indeed, Mitch, this is a really challenging time for global health. It's a challenging time for HIV. And if I look across HIV, TB and malaria, it's most challenging of all for HIV prevention. And that's both difficult, but we also have to take what are the opportunities in terms of how we respond to this together. We need to be more agile, more targeted, more collaborative in how we enable access to HIV prevention and how we deliver results. We need to give more attention to sustainable financing in scaling up access to HIV treatment and prevention, like strengthening community systems, community engagement, and working with the ministries of health here, but also extending to the ministries of finance to demonstrate how investment in HIV prevention is a great investment with fantastic returns. We need to continue to leverage the efficiency gains that we've made in the global health response. We've halved the cost of HIV treatment since 2018. That's allowed countries to scale up ART. It's also creating increased fiscal and financial space for financing prevention, including innovations. And to win in HIV, we must reduce new infections. The long-lasting HIV prevention options will have significant impact if offered to the right people in the right locations. And this will increase sustainability by averting lifelong treatment costs. And one example of that is certainly Global Fund's commitment that Peter Sands repeats to echo, to roll out lenacapavir to significantly bend the curve on new infections. And together with the other partners here, we have committed to supporting 2 million people with lenacapavir over the next 3 years. And we intend to prioritize investment in early adopter countries that are best positioned for impact and to rapidly roll out the product as soon as it is available. And then to scale up in other countries that are interested and at the moment that's suitable for them. A successful Global Fund replenishment later this year will finance the Global Fund partnerships to deliver on the ambition of lenacapavir to scale up other strategic areas. And the private sector is increasingly an important partner for us. The Children's Investment Fund and Foundation, CIF have already pledged $150 million for the Global Fund's replenishment, and part of that will be used to catalyze lenacapavir. I also want to call out the synergies between the Global Fund and the Global Prevention Coalition, especially in terms of how we support country-led responses. And I want to emphasize too that choice is an important principle in HIV prevention. And I want to also call out and thank too for the Minister of Zimbabwe recognizing the engagement with civil society and communities, because they are central partners for HIV prevention, especially in ensuring equity to access and new technologies like ELEN. So our shared goal is sustainable, country-led, cost-effective HIV prevention programs with the right mix of options and systems to deliver HIV preventions to the people with the greatest needs. So let's get on with accelerating HIV prevention together. Thank you.
Michael, thank you. And I'll just say fund the fund and invest in prevention. We can do both of those things. We're going to go from Michael to Michelle, staying in with European voices, however. You've heard a lot about lenacapavir. It was hailed as the Science Magazine Breakthrough of the Year in December last year, based on 2 remarkable clinical trial results. And we're delighted to have Michelle Joly, who is the Vice President for Gilead Patient Solutions and really leading the work to ensure that low and middle income countries access this life-saving innovation. So Michelle.
Yeah, thank you very much, and good evening, ladies and gentlemen. Thank you, Ms. Bianyama, UNAIDS for hosting us. Thank you, Michelle, for hosting me at this fantastic table. I think we all know and will remember the emotion on July 24th in Munich when Professor Linda Gale Baker faced a standing ovation presenting Purpose 1 results. It was really remarkable for PrEP, showing 100% protection against HIV. And you remember that it was also the first time that a drug was developed first for women in sub-Saharan countries, thanks to the guidance of the communities. And at the same time, we felt, the immense responsibility to make land available for people with the greatest needs, especially in low and middle income countries. So we made hundreds of consultations with communities, with partners, most of them being because we're working from him, to make HIV free regeneration. So I'm motivated, really. So we set 3 critical objectives, which is first, speed. We know that we cannot repeat the time where there were years between access of HIV treatment or prevention between North and South countries. This cannot be repeated. Volume, because 80% of the people are in those countries and they need high quality, sterile product, complex manufacturing process to happen. And price, because we are leveraging in Gilead our major experience in voluntary licensing to bring high volume and low prices, and to be committed also as Gilead to produce land before generic enter into the market. In September 24, we released the Purpose 2 results in more countries and different group of people. In September 24, at UN General Assembly, we announced that we will not wait generic country and we will launch manufacturing process at risk for millions of vials, which will be available at not-profit price for Gilead. October 24, we signed VL agreement with 6 generic companies, royalty-free, for 120 countries, which is, to my knowledge, the first time ever that VL agreement was signed before any regulatory submission, and the broadest numbers of countries for a VL agreement for an anti-HIV drug. December 24, we achieved the tech transfer to generic companies. December 24, Global Fund, PEPFAR, CIF, and Gates Foundations announced a coordinated effort to reach 2 million people with land for PrEP. February 25, we submitted registration to EU for All under accelerated review, which will facilitate access in low and middle income countries, and we prepare submission for 18 countries, which represent 70% of the disease burden. We work in parallel with WHO for pre-qualification, while WHO announced revised guidelines for PrEP for the next RIS in Rwanda. March 25, we submitted registration in South Africa. March 25, we submitted registration in Brazil under accelerated process. And for upper and middle income countries, we work with the country on a tailored tier pricing approach, including obviously the Purpose 2 countries like Argentina, Brazil, Peru, and Mexico. And so today, we are working hard with our partners, global partners, to make this ambition real, to end HIV for everyone, everywhere. And so I would like to sincerely thank all the partners which help us to build those bridges to a healthier world. Thank you very much for your attention.
Michel, thank you. There are a lot of moving parts to any intervention or any program and product, and I will just make a shameless plug. A lot of what Michel described, if you go to prepwatch.org, both the data related to PrEP that the ministers of health from Zimbabwe and Mozambique described, as well as all the moving parts to introducing lenacapavir, are available through the coalition's work. So prepwatch.org for those who want. There's a huge amount of work to be done to translate the science and the policies and the programs into action. But at the end of the day, this is all about community. It has to be centered around what communities want and need in this. And so we will now, before I turn it over to my co-chair to take us into a second panel, we have 2 final speakers in this first section who represent community. That's where this work really has to begin. It has to be its middle. It has to be its end. And it's particularly exciting that we have actually a 2-person kickoff for this first one, because Lillian has brought a special +1. I'm so happy to welcome Lillian Benjamin Wasoki from DARE organization from the United Republic of Tanzania, as she will often tell me. I've had the great pleasure of working with Lillian. She was an AVAC advocacy fellow before she was a mom, but I'm delighted that you are here not alone. but with the important next generation. So Lillian, please.
Yes. All right, thank you. Good evening, everyone. Right. It's okay. Good evening, everyone. My name is Dr. Lillian Benjamin Mwakiosi. I am from the United Republic of Tanzania. And I get the opportunity to speak before you tonight at such a critical time where global investments in HIV prevention and research generally risk turning a blind eye on communities who need them the most, especially girls and women who have long continued to bear the brunt of HIV and continue to navigate risk, HIV risk, not as a concept in meeting rooms, but a lived experience. In my country, Tanzania, every hour, 2 to 3 young women get newly infected with HIV. I know the case is similar or even worse in other sub-Saharan African countries. I like to believe this is because these young women are reckless. But because systems in place continue to fail them, existing HIV prevention options do not speak to the diverse and changing needs of girls and women in our communities. Additionally, access to long-acting PrEP options and newly advanced HIV prevention methods continue to be far-fetched for majority of us, including myself. At the organization where I lead, we have reached out to hundreds of adolescent girls and young women with information, exciting information actually, about advanced technologies in HIV prevention. The biggest question we always get is, where can I get them? And the excitement would fed to the hard reality that they're not available in our countries, let alone some not yet being registered. See, when we're talking about HIV prevention for young women, we have a lot of barriers that really can lead to existing HIV prevention options not responding to our needs. I'll start with girls who struggle to negotiate safe sex. We all know it's because it entirely depends on the other or their sexual partners. Additionally, I've sat with young women who are forced to hide their PrEP pills because they're scared they will be questioned by their families. So when we're talking about new prevention technologies and long-acting PrEP options for these young women, it's not just about scientific advancement, it signifies freedom. Freedom from judgment, freedom from daily reminders, freedom from risks we cannot control. As emphasized by the Choice Manifesto for HIV Prevention, at this point in time, choice for HIV prevention is not a luxury, it's a right. And so tonight, if we're serious about controlling HIV infections by 2030, we must provide young women with the tools to do so. We must ensure jointly access to the full spectrum actually of long-acting PrEP options, the dapivirine vaginal ring, lenacapavir, cabotegravir, to mention a few. In fact, I feel like the dapivirine vaginal ring is underrated. This is the first ever female-controlled and discreet HIV prevention option. We should be celebrating it. Yeah, so thank you. And going forward, I think we must make sure that we work jointly and make sure that we are able to address the needs of adolescent girls and young women comprehensively. So integration remains critical, especially now with the ongoing situation. I traveled all the way from Tanzania to get here, not only with urgency, but hope that going forward, based on decisions that will be made tonight, access to choice and HIV prevention tools, including long-acting PrEP options, will no longer rely on our geographical locations or affordability. Thank you.
Lillian, thank you. I failed to mention in Lillian's introduction, she's also a founding member of the African Women's Prevention Community Accountability Board that worked with UNAIDS and AVAC and others to create the Choice Manifesto. And I just want to take a moment to have everyone let it sink in what Lillian said. Choice must not be a luxury. It's a right. And I know there are going to be many great things that have already been said and will be said, but if you take nothing else away from tonight, take Lillian's wise words. So thank you, Lillian. It is about ending HIV for everyone, everywhere, and it's about all populations. And I really am excited to turn to the relatively new executive director of the International Network of People Who Use Drugs Input, Anton Basenko, to provide a perspective of how critical it is. Because when you look at the epidemiologic curves, we can't only focus on adolescent girls and young women in East and Southern Africa, but it's about the rights of choice too amongst people who use drugs. Anton.
Thank you. Thank you. But before I begin, I would like to offer my sincere condolences on the loss of our colleague and friend this night, Naomi Bergshine, longtime Executive Director of Harm Reduction International. Her contribution to the global development and advocacy of harm reduction and prevention programs, especially for people who use drugs, is invaluable, and it is impossible to find words to express the sadness of such a loss. Distinguished delegates, colleagues, thank you for having me here, and thanks to UNAIDS that always providing space for raising the voices of communities. I speak on behalf of the community of people who use drugs, a community on the HIV front line facing a funding crisis. Donors are shifting priorities, and funding cuts are literally cutting the harm reduction sector at the knees. I carry the testimony of peers worldwide. An Eastern Europe group told us we can barely make ends meet. We are financing from our pockets and volunteers to keep syringe and HIV prevention services running. In Africa, peers warned that layoffs let people return to heroin use and sharing needles, driving new infections. In Southeast Asia, NGOs report people are scared essential services are discontinued. Input survey confirms this. 43% of organizations saw syringe programs disrupted, and 30% saw overdose death increase. This is dangerous because people who use drugs already face criminalization, stigma, and exclusion from health services. Community outreach is our lifeline. Peer-led outreach, critical for trust and linkage to care, was often the first service cut. Prevention must be comprehensive. Condoms and lubricants, sterile syringes and substitution therapy, naloxone and both daily and long-acting PrEP, long-acting depot buprenorphine for the opioid agonist therapy. But new injectables are welcome, but they must add to, not replace, the basics. The call is urgent, especially to country governments. Maintain and increase investment in community-led combination prevention. Support pool funding mechanisms and direct grants to networks of people who use drugs. The Global Fund accounts of 73% of global harm reduction support and remains our last buffer against collapse. We urge it to prioritize harm reduction co-financing and dedicated funding streams for key populations, and to establish an emergency pooled fund to protect services. Without bold action now, decades of progress will be lost. Our community is ready to deliver prevention if supported. Stand with us, because without us, there is no sustainability and no end to HIV. Thank you.
Thank you so much, Anton. And without community, it doesn't happen, no matter how good the science is. Thank you. It is my great pleasure to turn over the leadership of this session to my friend Nduku Kalanza, who, when the Global Prevention Coalition was founded, she was also a leader of that coalition in wearing the hat of the National AIDS Control Council of Kenya. But I'm delighted tonight that she's here as the co-chair of the coalition itself.
Thank you very much, co-chair. And all protocols observed. I come from government, so I must always observe all protocols. Good evening, everyone. My name is Dr. Nduku Kilonzo, and I'm not only the co-chair of the Global HIV Coalition, but I also provide support, technical support to the HIV Leadership Forum, which is a community of practice of director generals of national AIDS commissions or coordinating authorities from Asia, Africa, and Latin America. We have heard a lot today about the bold visions and the leadership commitments and actions that have been taken. And I want to echo a question that Winnie started with, the executive director. What will each of us do? And so this session is going to ask, how do we get there? How do we turn the commitments, the ambition that we have into the realities? We've already had action from countries. We have already had action from the market. We have already had action from the communities, but we've also had the needs and the gaps that are there. So as I turn to our panelists, I am going to be asking each panelist to remember that we have only 3 minutes. It is not enough time necessarily to talk about all the actions that we all must do, but we do need to be asking ourselves and answering the questions. Now that we are here and we have an opportunity and we have a product, what do we need to do? How do we move forward? I would like to start the practical steps by introducing Dr. Meg Dawati, Director, Global HIV Hepatitis STI Programs. I've known Meg for many years, to share reflections on what is needed and to introduce long-acting options as part of the prevention response, because they are a part of the prevention response. Welcome, Meg.
Thank you very much, and all protocols observed, excellencies, everyone in the room, and thank you very much to UNAIDS, the Global Prevention Coalition, who invited WHO to be at the table. Our DG delegated me, and I think I may start with my very first comment on is World Health Assembly is happening. We have to be really excited about the fact that the pandemic agreement has been approved. And that means it reminds us that we need that same urgency around HIV as we do with the pandemic around the world. And you probably heard already that new infections have been stable for several years running. We don't know what the disruptions that are happening now will impact on that as we go forward, but the long-term debt is just not acceptable at this time. And where we were thinking we were ending AIDS as a public health threat, we are now thinking about how do we retain, not slip back, use treatment as prevention, but also really benefit from the innovations that we've heard about already, the long-acting innovations. One thing to say is WHO's, our main role is to be able to be the norms and standards setting guidelines out, and that is what our job is, to be able to get these innovations out. We have a recommendation around vaginal ring. We've had a recommendation on long-acting CAB-LA since 2022. And now I can say hot off the press, our guideline review committee has approved our guideline. So we'll have a guideline launched in July 2025. This process of doing the lenacapavir PrEP as a guideline with also with it simplified testing of using rapid diagnostic tests is part of what we call a 12-month alignment process, where we're aligning from the time that there's a critical new study out, and that would be the Purpose 1 and 2 trials, that within 12 months we can have a recommendation and a pre-qualified product. We are working on that with all of you and in partnership, and we are going to make our timelines. So we have been responding by looking at the data. And as you probably know, we put out what's called an expression of interest so that both the originator and the generic companies know what to do to get pre-qualification. And again, we're working with both the US FDA and EMA Medicines for All, so that the moment that the Medicines for All is approved, there will be an approval that will come very shortly thereafter for WHO pre-qualification. So we've aligned our ducks, working with both the long-acting PrEP coalition and all the partners here, but also now our next step is moving into countries. And I think the most important thing that we need to be doing with countries is helping them already understand what's in the guidelines, how to adopt and adapt that soon, and then working with all of the regulatory bodies in countries so that they can have a smooth ability to approve the use of LEN. The other thing that we're doing is we're looking, and with many of you around the table, looking at where will the use of LEN PrEP be most effective in this time when we have very limited resources. Which countries, which populations, how do we do it in the first instance so that when we have demand creation, that there is a supply there. And so I think that builds confidence with communities, and we take that very seriously. So we're looking at this sustainable integrated systems, and you may have heard a little bit what's happening with WHO. We're uber integrating right now. So we see that, you know, implementing in different settings, antenatal care, family planning, STI, TB, primary care platforms, using the kinds of tools that have worked so well with antiretrovirals, decentralizing into communities will allow us to be successful jointly. We learned one thing about with dolutegravir is that we need to know what's happening in pregnant and breastfeeding women so there's equity. So in the studies, 200 pregnant women were already studied. We've seen their safety. So our next steps are we're working on post-market surveillance systems, toxicity monitoring, monitoring in pregnancy and breastfeeding, and setting up systems for drug resistance monitoring. So let me just end by saying 4 suggestions of how we can make these widely available that requires all the partnerships that you discussed. Is we're calling on and we're asking pharmaceutical and generics to really publish their transparent pricing when available, and also work on the bioequivalent studies for the oral lead-in. And we know that's going to be critical to bring this to bear. We hope our ministers, our excellencies can commit to put this into their national HIV plans and their national health plans and budgets. We'll work with you on that as well. For all of the other agencies to commit to pool procurement at some point as things move to generics, and communities, again, leading on demand creation, but also holding us accountable. We're doing our own accountability about our timelines, we're making them, but the next phase, I think, is where the rubber hits the road. Can we roll out both the originator in 2026 and generics that may be coming earlier than one thought, and have it be effective, efficient, and impactful? So thank you very much.
Thank you very much, Meg. I think in following with Mitchell, 30 more seconds for mentioning all the work that needs to be done. Thank you. It is now my pleasure to turn to a country, Philippines, and Philippines has been actively responding to an HIV epidemic that has been growing rapidly. So, Excellency, Honorable Teodoro, the question that I would have for you is, as you engage in strengthening your HIV prevention response and controlling your epidemic, what do you see as the role of new prevention technologies?
Thank
Welcome,
you.
Your Excellency.
Yes, honorable ministers, excellencies, esteemed colleagues, partners, a pleasant good evening to everyone. The Philippines continues to confront a growing HIV epidemic, one of the fastest rising in the Asia-Pacific region. This reality compels us to strengthen our national response with urgency, resolve, and sustained commitment. We are advancing a prevention-centered approach that is inclusive, country-owned, and designed to endure, anchored in our shared goal of ending AIDS as a public health threat by 2030. We find ourselves in a pivotal moment. Prevention is and must remain the cornerstone of our response. Our national strategy is guided by 3 foundational pillars. First, we are institutionalizing prevention within our universal health coverage system. The 2018 HIV and AIDS Policy Act has laid the foundation for expanding access to essential services, especially for key and vulnerable populations, including our youth. We have integrated HIV prevention, including oral PrEP, into public health programs and are working to expand PhilHealth's coverage, our national health insurance, for HIV-related services, ensuring long-term financial sustainability. Second, we are committed to scaling up and diversifying prevention options. Oral PrEP is now available in more than 80 sites across the country, with recent guideline updates enabling same-day initiation, adolescent access, and community-based distribution. We have introduced HIV self-testing and dual HIV syphilis rapid diagnostic kits to enhance reach and convenience. The Philippines is actively working with partners to accelerate the introduction of long-acting PrEP, navigating regulatory, pricing, and operational pathways to ensure timely access. Third, and most critical, we are strengthening our country ownership through a multi-sectoral collaboration. Through leadership of the Philippine National AIDS Council that I chair, we have localized the HIV response, bringing them to the community. You'll be happy. Empowering local governments, civil society, youth networks, and key populations. We are integrating HIV and AIDS education into our basic and higher education curricula. In collaboration with our Department of Education, our Commission on Higher Education, and Technical Education and Skills Development Authorities. We are also harnessing digital innovations to discreetly link individuals to services and prioritizing inclusive planning and budgeting at the local level through strengthened local AIDS councils. To anchor these efforts, the HIV Financing Sustainability Roadmap offers strategic direction for aligning domestic resources with policy reforms emphasizing good governance, efficient service delivery, and innovative financing mechanisms. As a committed member of the Global HIV Prevention Coalition, the Philippines is finalizing a national HIV prevention roadmap to drive alignment with global targets and accelerate impactful solutions. However, we must acknowledge a looming challenge, which is the gradual reduction of international assistance. For many years, donor support has catalyzed innovation and scale. Today, we must transition towards a more resilient, domestically financed response without compromising equity or progress. In this new era of HIV prevention, global solidarity remains essential. We urge partners to support pooled procurement, cost sharing, and equitable access to innovations and technologies for low and middle income countries. The Philippines stands ready to lead with resolve, to learn from our peers, and to act in solidarity with our communities at the heart of everything we do. Thank you very much.
Thank you very much, Dr. Teodoro Arbosa, for your insightful example of country ownership and really how you're leveraging the whole of government through a multi-sector response to be able to deliver on prevention and the resources needed. I want to now turn to West Africa and to Ghana, and I would like to invite Professor Samuel Kaba Akoreia. Akoreia, is that how you pronounce it? I hope I'm not too far off. Thank you, welcome. And really is that Ghana, you're reinvigorating your HIV prevention response, even at this time of funding challenges. So would like you to give us some ideas and some insights into what you are doing. Thank you.
All right, thank you, Madam Chairwoman, and Excellencies, President, and all dignitaries. Ghana's strategic response has been based on the building blocks of efficient response to any disease. And these are prevention, promotion, treatment, supportive measures, and rehabilitation, which could be mental, physical, or stigma reduction. This is backed with strong political will, community leadership and engagement, data-driven accountability with line-by-line revision to eliminate duplications and efficiencies. Gain is also backed by sustainability, which is usually by ownership and solidarity with our neighbors. In political will, the HIV prevention roadmap has been developed and costed operational plan backed by multi-sectoral consensus with clear measurable milestones and KPIs for the people to achieve, with a clear goal to achieve an epidemic control by 2030. The government has introduced the Ghana Medical Trust Fund for chronic illness, which includes HIV, with the concept that a healthy population is a wealthy country and we are all potential patients and no one should be left behind. Government has supported and is supporting the National HIV Prevention Summit, which we initiated in 2024. And government supports national and subnational HIV prevention cascades and scorecards reviews. These interventions have seen a reduction of new cases in between 2023 and 2024 from 17,000 to 15,000. In the promotion and prevention era, there is a strategic plan on community leadership. There is a plan on engagement of CSOs and NGOs, targeted engagement with communities most affected, as we said, is by data-driven, and these include adolescents, girls and young women, and of course, boys. We have developed a strategy for a year-round press and media engagement in a digital form, and this leads us to the schools, workplaces, including the markets, and entertainment areas, like clubs, discotheques, the rest. In the form of prevention, treatment, and innovation, the government has ensured timely access to treatment. And in the last 3 years, the government spent over 10 million on prevention interventions, and with plans this year to spend and procure over $15 million worth of HIV commodities, which will include condoms, test kits for pregnant women and infants. This year, we intend to introduce the Pevrin vaginal ring targeting sex workers, women who use drugs, and adolescent girls and young women. This empowers them whenever their negotiation capacity fails. And we will pilot the long-acting injectable cabotegravir for HIV prevention. And we have initiated discussions on LIN as well. These innovations will transform our national fight in the prevention of HIV, whilst we search for other avenues of resource mobilization, which will include public-private partnership and integration of the HIV in our national health budget, and make sure that there is 100% accountability to ensure efficiency. Thank you.
Thank you very much, Professor Kaba. And I think as I hear about the HIV Prevention Summit, which is an innovation that very few people have actually taken, very few countries have taken on, and you're continuing to do it, we truly appreciate that. And finding people where they are. I heard you mention about going to clubs. It's not every day that we hear interventions to find people exactly where they need to be to get prevention interventions. I will now turn to China. China is a country that continues to demonstrate strong leadership in public health governance, as well as innovation at scale. It is now my pleasure to invite Mr. Jia Gang, the Vice Administrator of the National Disease Control and Prevention Administration of China. How do you build a sustainable HIV prevention model?
Thank you, Chair. Excellencies, honorable guests, ladies and gentlemen, good evening. HIV/AIDS is still a major public health issue worldwide. The Chinese government has continuously attached great importance to HIV/AIDS prevention and control, and advanced it as part of the Healthy China initiative. Prevention is the most cost-effective health strategy. Prevention first is a key component of China's health policy, which is clearly stipulated in the laws and the regulations, such as the law on basic medical and health care and the promotion of health, the law on the prevention and the control of infectious diseases, and the regulations on the prevention and the control of HIV/AIDS. Multiple national prevention and control plans have all taken prevention first as a major working principle and the prevention strategies as more measures. First, take HIV testing as the entry point for treatment management and the prevention of transmission to detect as many infected individuals as possible. In terms of service provision, we make testing more accessible and convenient through various medical and health institutions at all levels. Voluntary counseling and testing networks, self-test. In terms of population coverage, we provide outreach tests for high-risk population. Medical institutions provide testing for patients in key departments. HIV testing has also been included in routine tests for pregnant women, and voluntary premarital medical examinations are also provided to young couples. Currently, over 400 million HIV tests are conducted annually. Second, prioritize preventive interventions measures to effectively prevent HIV transmission. Condoms are available in all public places, facilitating their distribution to people living with HIV. Methadone maintenance treatment has been an important measure for IDUs. The new infection rate among those accept MMT has dropped to 0.03%. We have upgraded guidelines to promote post-exposure prophylaxis and standardized pre-exposure prophylaxis. We have established a fund to support NGO to participate in HIV/AIDS prevention and control, through which over 10 million key populations can be reached and got intervention. Comprehensive prevention services have been provided for the serodiscordant couples, reducing the transmission rate to lower than 1.3%. We are carrying out national action plan to eliminate mother-to-child transmission of AIDS, syphilis, and hepatitis B, and HIV mother-to-child transmission has reduced to 1.3% and on a downward trend. Third, take great efforts to implement the treat as prevention strategy to improve treatment coverage and quality. China has fully promoted HIV one-stop services, integrating test, diagnosis, and treatment in one place to offer timely treatment to new reported cases. HIV/AIDS treatment guideline has been updated with the introduction of new ARV drugs. Notice more than 50%, more than 95% of people with diagnosed HIV infection are receiving ARV treatment and got viral suppression, significantly reduce the risk of transmission. Fourth, fully leverage the role of social vaccines to form synergy in preventing and combating HIV/AIDS. Peng Liyuan, First Lady of China and the WHO Goodwill Ambassador for Tuberculosis and HIV/AIDS, has participated in promotional activities for 20 years. Advocating for in-depth collaboration between social resources and official institutions, and fostering a social atmosphere of caring and supporting people living with HIV. Fourth, continuously increase financial investment to ensure a stable and sustainable support mechanism. We have established and steadily increased government special funds for HIV/AIDS. In 2024, the investment has reached 9 billion yuan, laying a solid foundation for the continuous HIV response, including prevention efforts.
Thank you very much.
With unremitting efforts, China has established a prevention and treatment service system that covers areas from publicity and intervention to treatment and care, provide health service to cover the entire population, the entire life cycle, and the entire process, basically achieving the goal that everyone can get HIV test at the township level and get ARV treatment at the county level. Currently, blood transmission of HIV/AIDS has been basically eliminated, and mother-to-child transmission and injecting drug use transmission has dropped to the lowest level in history. Overall, the epidemic is under control at a low prevalence level. Ladies and gentlemen, HIV/AIDS prevention and control is an ongoing task for us, while ending epidemic is our common goal. Let's join hands and work together to promote the early realization of this goal. I would like to conclude my speech with what China once advocated for the World AIDS Day: full participation, full commitment, and a universal prevention. Thank you.
Thank you very much. I know I did almost take away some of your time. I didn't realize you were still going on, so thank you. And I think we have heard a lot from China. I think for me, one of the most important key messages is prevention is the most cost-effective strategy for the response. And I think it can't be better said. And I really want to now take this opportunity to invite Germany. I would like to invite Ambassador Nicola Gilhoff from Germany, from the permanent mission of Germany. And Ambassador, I think Germany has consistently championed strong investment in HIV prevention as part of the broader health response. And as we move forward towards the sustainable development goals, prevention remains a critical part. So why do we need to push prevention to reach the SDGs?
Thank you, Madam Co-Chair. And well, Excellencies, colleagues, ladies and gentlemen, thank you very much for taking part in this very important discussion today. which couldn't be timelier to discuss really prevention from all various angles. And you said it already, prevention is really key in eliminating HIV. So today's topic couldn't be timelier, given the sudden program stops and also the threat of rising HIV infections due to that. So we need a laser sharp focus now on what is needed to ensure the epidemic is not coming back. After more than 40 years of HIV, we have the tools and knowledge needed to tackle the virus. Recent data shows that the 2030 targets were within reach. So now is the time to protect this progress and to focus on interventions that can be a game changer for the global HIV/AIDS response. Long-acting medicines for prevention that offer protection almost like a vaccine are these game changers that we have been waiting for. They are essential to getting ahead of the rising curve of new HIV infections. The sudden funding stops and its consequences for people are heartbreaking. But they reflect a bigger trend over the past years. As ODA budgets shrink, countries will have to increasingly take ownership of their national HIV/AIDS response so that it ultimately becomes sustainably. And strong prevention programs, as discussed also on national level, closing the tap of new infections are the only way to ensuring the sustainability of this response. That is why we must find affordable ways to bringing new innovations to the people, and we thank UNAIDS for playing their part. I was delighted to learn that Gilead has already signed several voluntary licensing agreements for generic lenacapavir. This is a strong sign of global solidarity, and we encourage them to continue this important work. However, amidst all the medical prevention advances, we have to further strengthen the well-established traditional behavioral prevention interventions, including SRHR, comprehensive sexuality education, and harm reduction. And we must not forget that preventing the spread of the virus means addressing fundamental aspects, including discriminatory legal and social barriers, and ensuring that human rights are upheld. Because when long-acting medicines become available, our health system must not be stigmatized or discriminatory to the very people that we need to reach. This is a key area in which each government must play their part. In my own country, Germany, we also had to adapt laws, change rules and guidelines to ensure that we reach those populations most at risk of HIV infections with HIV services and prevention tools. Germany has long been a strong supporter of the HIV/AIDS response through our support for the Global Fund, UNAIDS, and bilateral initiatives. And we continue to stand in solidarity with those in need. As we move towards 2030, we are working with partners to leverage prevention and suitability of the AIDS response so that we can end this endemic. Thank you.
Thank you very much, Ambassador. And, for the clear call to action and specifically call for global solidarity, especially in these challenging times. We now turn to the private sector, which plays a crucial role in enabling access to innovation. We already heard before from Gilead about what they have done, even without the guarantees that they usually have before they move forward, and we thank them for that. It is now my pleasure to invite Sylvia Vito, the head of Africa in Eva Pharma. What role can generic manufacturers play in increasing access and equity to long-acting injectable options?
Thank you very much, and distinguished guests, our conveners, our hosts, various governments, ladies and gentlemen, all protocols observed. It is a pleasure to be a part of this conversation. As mentioned by our chair, I'm Dr. Sylvia Vito, and I serve as the Africa head for Eva Pharma. Eva Pharma is an international pharmaceutical manufacturing company based in Egypt that actually was one of the recipients of the voluntary license. And it is a pleasure and it was an honor for us to be able to serve the population in this particular way. beyond our focus, not only innovate and manufacture life-saving medicines of generics, it has been very critical for us to continue partnering with global innovators such as Gilead in the supply of breakthrough treatments and solutions and make them not only accessible, but affordable and available in good time. So for us, it was a big deal that as an African organization founded in Africa, based in Africa, is one of the VL beneficiaries, and we're able to manufacture lenacapavir here on the continent, not only to supply Africa, but other middle income countries. So this happened about 6 months ago, and we've been busy. We've been busy since then. In the last 6 months, we are still in the phase of what we call product development phase, and we're really accelerating so that we can ensure that in a very short turnaround time, we're able to pull through the entire product development and manufacturing and local registration in the country of manufacturing before we can then submit for approval to be able to export to the other countries. Because as mentioned earlier by our Gilead Vice President, we will be part of the suppliers to 120 countries of the generic lenacapavir. And of course, for us, the phase 1 of the exports will be targeting 18 countries that represent the highest incident rates, which is 70% of the HIV burden. So the VL has laid a very great foundation for regional local manufacturing. And this is what it means for us. Number one, because of the VL voluntary license and the local manufacturing and the public-private partnership, it means we're able now to scale up on the supply side. There is number one, the accelerated technology transfer that has been received. And this is a big deal because not only has it built our capacity as Africans, but has also built our capabilities for complex manufacturing. That's number one. Number two, it has forced us as a private entity to step up our investment in the infrastructure that leads to high-scale facility manufacturing that we've done. And this is going to last a very long time because I think success begets success. It will also encourage other local manufacturing to step up the level of investment and also attract more investment for local manufacturing. But that's just as far as what we've done so far. There are a lot of things that we are yet to do, and which is the pathway that we're taking. Number one, the regulatory acceleration is a very important outcome of regional manufacturing and a public-private partnership that accelerates access to equitable care of long-acting PrEP medication. So in this particular pathway, we are looking to a lot of partnership with Africa Medical Agency. We are looking out for WHO with the support on WHO pre-qualification, as was mentioned by Meg, and of course, plus all the other collaborative regulatory partners to help us harmonize the registration pathway, because as you can imagine, there's a lot of fragmentation and a lot of the countries in Africa are at different stages of even ML3 maturity. So through the harmonization process, which is what we want now to take through, it will enable us to bring this lenacapavir closer and accessible to the last mile for the African patients and patients in the other lower middle income countries. So that's number one. The other component is around the shared risk and cost reduction. The public-private partnerships is important for us to work with governments, with critical stakeholders in HIV, such as UNAIDS, WHO, Global Funds, and other health organizations to enable us have supply agreements that ensures prices are well negotiated. And for us, it's important that it will be an equitable price that is accessible to any patient that might require lenacapavir, so that we remove the barriers that actually lock out a lot of the not so affording parts of our population. So this is critical for us so that we actually are able to take it through the different financing models to ensure that the lowest unit costs are actually the outcome of why we got this local manufacturing and why we got the voluntary license. And of course, this will have a knock-on effect on also faster distribution and strengthening of the supply chain. Beyond that, I think also on the demand side, it's important that I mention that some of the key outcomes of regional manufacturing and public-private partnership in accelerating sustainable and equitable access to lenacapavir, for example, is that there will be need for us to come together and talk about pooled procurement, because this will help us leverage the economies of scale of the total market that we're looking at so that we can drive up affordability and ensure there is sustained demand and supply. There is need for conversations as we step forward into formal supply agreements with our governments, and a lot of them represented here, and all the stakeholders, so that we ensure that lenacapavir is not locked out for anyone. There will be no stock out, and there will be continuity of care for our patients. Of course, in some of the public health programs, we are looking out to different programs to look at bulk purchasing agreements, and of course, giving the same prices across the public sector to ensure that both there is alignment in not only the supply agreements that we are working with, but that this is aligned with the national health policies. Because HIV and for HIV and lenacapavir, this is the broader strategy to really combat HIV. And probably, as I just try to conclude very quickly, is to mention that for us, regional manufacturing and these public-private partnerships have enabled increase in trust and collaboration between manufacturers of generic medicines, such as lenacapavir, governments, plus all the other critical stakeholders, because together we need to address the public health need that we tend to see in our countries. So for us, these are critical steps that we are actually taking to ensure that we scale up the utilization and the access to the last mile of lenacapavir, not only in Africa, but to other lower to middle income countries. But of course, talking about also the whole real world data generation that will actually be availed as a result of this medicine. But it is a big deal because Africa will no longer have to wait for 10 plus years to accelerate or to access innovative medication. So thank you very much to Gilead and to all the stakeholders, UNAIDS, Global Fund, and every other organization that was behind ensuring that access to generic companies to manufacture lenacapavir becomes a reality. Thank you very much, Madam Chair.
Thank you very much. I think we can all see the passion coming through, isn't it? So I really appreciate your presentation around the power of PPPs in terms of looking at how to shape markets as well as bring services closer or products closer to people and strengthen local supply chain capabilities. It is now my pleasure to move us a little bit forward and ask the next presenter, who is also presenting virtually, Mandeep Dhaliwal, the director of UNDP's HIV and Health Group, really to help us think about how we better address structural access barriers and as well as enablers for us to be able to deliver long-acting prevention. I will also just ask that we keep to the 3 minutes, please.
Thank you, Excellencies, esteemed co-chairs and colleagues and friends, and all protocol observed. That is a tough act to follow, Dr. Vito, but I'm going to make an effort. Thank you very much for the question on structural barriers and enablers. I think it's vitally important. And my remarks today are really grounded in the work that UNDP, both as a co-sponsor of the UNAIDS joint program and also as a close partner of WHO, UNFPA, the Global Fund, and others, the work that we're doing with countries and communities to scale up PrEP, for example, in Zimbabwe, Tajikistan, Congo, Pakistan, among others, as well as the work we're doing in over 80 countries to reduce stigma and discrimination, work on HIV prevention for key populations, and create the kind of enabling environment that we need to really accelerate HIV prevention. So the first thing really is that the evidence has shown us for years that structural interventions, enabling legal and policy environments, drive down the curve of new HIV infections so that we accelerate HIV prevention. So this is critical. Now, the work on addressing structural barriers doesn't happen just in the health sector. Without a doubt, the critical integration in health plans, budgets, in our efforts to scale up universal health coverage, including to sexual reproductive health services, is vital. And that must happen, and that must pick up pace. And we must address the barriers in the health sector as well. But if we're really going to make progress on addressing structural barriers to HIV prevention, we also need to integrate and step up the efforts in the justice sector, in development, and in finance sectors. The fastest path to sustainability and integration is by removing structural barriers to HIV prevention. We know that stigma, discrimination, criminalization of the populations who we need to reach with long-acting are critical barriers, violence as well. Those require multi-sectoral responses. What are the things that we need to do? We've heard from a number of the panelists very eloquently, but let me sum up a little bit. We need to ensure access. We need to look at price, registration, regulatory frameworks, and we need to innovate in terms of how we drive these issues forward. And I'm sure my colleague and good friend, Dr. Tenu Avafia from UNAIDS is going to speak to some of these issues. We also need to empower communities, civil society organizations, and health workers. And we're at a time when the entire infrastructure of community responses that we have built is under threat. We need to find innovations in keeping this going and really expanding it in our efforts to scale up access to long-acting prevention technologies. We need to improve the laws, policies, and strengthen the institutions. We know that strengthening, enabling legal environments and policy environments just doesn't happen with advocacy. It also happens with very important work with judges, with lawyers, with paralegals, with parliamentarians, and with communities. So we need to make sure that this work that is led by justice sector, by communities, by the development sector needs to happen as part and parcel of the HIV response. And we need to really leverage technology and innovation. Before COVID, would we have ever considered multi-month prescribing? Can we consider self-administered long-acting PrEP? So what are some of the innovations that can really help us scale, which are really critical? One of the messages that I'd like to leave you with is that we also need to look at making sure that the work and the investment in addressing structural barriers, stigma, discrimination, disabling laws and policies, and criminalization needs to be part and parcel of essential life-saving services. It's not something on the side that's going to happen by accident. It has to happen by design, and we have to see it as part of the package of essential services, of essential life-saving services. And the final thought I'd like to leave you with is, as we scale up long-acting and we accelerate this technology, getting this technology to the people in need, we need to look at the regional and population disparities that exist already. We know that transgender people account for less than 5% of the coverage of PrEP globally already due to stigma, discrimination, and a lack of appropriate services. Sex workers and people who use drugs are rarely prioritized in PrEP programs. And while we're seeing progress in terms of reaching adolescent girls and young women, the retention is low. For men who have sex with men, we see the highest uptake in wealthy countries, but it remains low in criminalized settings. So we need to take into account these population disparities as well as the regional disparities and really tailor our efforts and our investments to make sure that we are addressing these. So my final message really is that structural barriers matter. We have the solutions. We need to make the investments in addressing these across sectors and across populations if we are really going to realize the bold promise of ending AIDS as a public health threat by 2030. Thank you very much, Madam Chair.
Thank you. Thank you very much. As you can see, I am trying to get us to the finishing line. We have run a little bit over time. I thank you very much, Dr. Mandip, and I would like now to turn to UNAIDS and invite Dr. Avafia. Is that correct? Thank you, the Deputy Executive Director, to speak to us about the lessons from Kabele pilots that you have and transition and what countries need to do. Welcome.
Thank you very much, Madam Chair. Good evening, Excellencies, colleagues, and friends. Thank you to the organizers for inviting UNAIDS to offer our perspective. I am fully cognizant that I'm the last speaker between you and a very well-deserved drink at the end of a long day at the World Health Assembly. So I'm going to use my 3 minutes to try and make 3 points. I think the first one I want to leave you with is integration. And I want to share with you something that a member of our board, our communities delegation, said at a G20 meeting on primary healthcare, but it is as relevant for that as it is for this. She said, I'm a person with a number of health needs. So don't cut me into pieces with your vertical programs when I go to hospital. And my takeaway from that for us is that we should be supporting country-led programs that integrate the introduction and the scale-up of a range of technologies into national programs. Because people who will use lenacapavir or Cabernet or the ring will also need treatment for non-communicable diseases. For family planning, they'll need access to a range of prevention services. So the days of silos are behind us, and I don't think we can afford that luxury anymore. That's my first point. The second one is efficiency. And again, as we've heard from so many speakers from WHO as well as from the private sector, we don't have the luxury to allow technologies to meander their way through the health system. So it was very encouraging to hear from WHO about the rapid development of guidelines, about pre-qualification. We've heard from generic manufacturers who've been licensed on the steps they're taking to get to market in an expedited way. My appeal would also be that we continue to support communities and civil society to help to navigate those access barriers, because that's where the knowledge in many country contexts are. And in addition to providing their knowledge, it's also about holding us accountable. So from our perspective at UNAIDS, we are more than happy to share our experience of introducing and scaling up oral PrEP, the vaginal ring, cabotegravir, and then hopefully to work with you also on lenacapavir. My last point is one of sustainability, because at the end of the day, price is a key determinant of access, as we all know. And in this time of reduced resources, I don't think we can afford to build bridges that are not connected to something. So for us, sustainability means co-creating the introduction and the scale up with country stakeholders. I mean governments, but I also mean communities, I also mean civil society and NGOs, to offer a range of interventions, because as a wise woman in this room said, choice is a right. It's not a luxury. And for me, that's an important message for us to also leave here with. So just to end by saying that we at UNAIDS stand ready to work with the coalition and with a broad range of partners here today to accelerate equitable access to long-acting preventatives.
Thank you very much, Dr. Tenu. And we have come to the end of our speakers. I would have wanted that we have a nice long session of a discussion, but I can see we are already getting really tired. I would also like to take this opportunity to acknowledge Excellency Honorable Minister Somse from Central African Republic, who is here. Thank you very much for sitting through the meeting. I would like now to invite Ambassador Paul Bakers, the permanent representatives of the Netherlands to the UN, Ambassador, to just make some remarks, thank us, give us some direction. Then after that, we shall be free to have further discussions and engagements upstairs. Please remember to ask all the panelists all the questions that you wanted to ask them as we engage upstairs. Thank you very much. Welcome, Ambassador.
Thank you. All right. All right. Well done. Thank you. Well, that was a trick I learned from a Chinese representative. I already had my first applause, but wait for the second. Thank you. And yeah, closing a session is always a very daunting task, but ministers, excellencies, ladies and gentlemen, it's a great honor. And actually, I'm co-chair. I'm contrary to your perception. I'm actually very pleased and honored, because when I saw the program and saw that I would be speaking at around 8:30, I thought, well, half the room will be empty and the other half will be asleep. But contrary to that, it's very lively and vivid. So thank you, and I feel honored that I can speak to you right now. At the same time, what can I say? What has not been said yet, but what can make us feel hopeful and ready for action? I can make it very short, adding to what Mitchell and the director of UNAIDS just said. Choice is not a luxury. choices are right. But that's a short version, and I think I should give you some more reflections. And I'd like to come back to the executive director, Winnie, who said in the beginning, she said, let's mention the elephant in the room. I want to come back to that point, because I believe we are certainly at a point when the reduction of funding to HIV response can lead to the dramatic reversal of what has been achieved. And that is sad. At the same time, that's the other side of the coin that we currently are at, is that countries could and should seize this global crisis as an opportunity to focus on the last mile of the HIV response. And I want to share a few observations. I want to share two positive observations, and maybe I'll add two negative ones. The positive is the following. We heard many countries speak, and you see how countries' political leadership can bring positive change in HIV response, providing space for the marginalized communities. And that's not everywhere yet, but I think those country examples shared with us today give hope that there will be more and other countries to follow. And the second positive observation is the fact that I would say, I mentioned it's positive, but it also is a little bit frustrating because we have everything we need to control the HIV/AIDS epidemic. It's astonishing that we haven't already achieved more, because we have the medicines. We know which social barriers have to be addressed to make HIV services accessible. We know how to involve communities to reach the most marginalized ones. And we have a scientific breakthrough in long-acting prevention with lenacapavir. But that's hopeful. And what is missing? What is missing is global solidarity and smart investments. And we are living in challenging times when development cooperation is being deprioritized. Other priorities are chosen. There's a major political shift. We see funds shifting to, say, for instance, the arms industry. I will give no judgment on that, but I will definitely not defend it. And as a vice chair of UNAIDS board and the future chair, I recognize a deep anxiety about the future of the HIV/AIDS response. And actually, I'm with you on that. I share that. Having said that, and I see my German colleague Nicola is here, and I like to quote the poet Goethe. Goethe said, "Happy is the man who early learns the wide chasm that lies between his wishes and his powers." The wishes are, it would be different. That's our wish. Well, let's see where our power is, and let's see where we can gap the difference. The power is that we all have the same aspiration, an AIDS-free generation. And let us use this aspiration as a power to keep us united and focused while marching this last mile. And the promise of an AIDS-free world depends on three things: on how the challenges of the current crisis is being managed. Secondly, how much courage we all have to take painful but necessary decisions. And three, how much support we can offer to those who are at the front line. Now you can say, oh, that's all nice words, but we are here, come back to the AG. What will we do? And I would like to share 5 or 6 points, and I'll be brief. But also let me use another quote by Bertrand Russell, who said, "Real life is a perpetual compromise between the ideal and the possible." I think there are 5 or 6 points that are both ideal and possible and feasible. The first one would be, we need to sustain the gains made in scaling up treatment and basic HIV preventions. Sustain the gains. We should not regress. Secondly, in listening to the country leadership this evening, we need more country-led HIV prevention responses. You need more sustainable implementation models and more domestic financing. So it's country-led. The third observation, we need continued international solidarity and financing, including through the Global Fund, the UN, and civil society. And the HIV response is so unique, so exceptional, that has the platforms for action at a global scale. And we should use it. My fourth point, we need to rapidly prepare the rollout of new long-acting prevention. We heard Mariangela speak about PrEP. Others mentioned it also, Brazil. Brazil committed to giving access to PrEP in the past and delivered. Now we need the same leadership for long-acting PrEP. My fifth observation, and I also heard it this evening, we need people-centered programs for key populations, women and girls and men at risk of HIV, to ensure that the people of highest risk can access services. And my last point is the following: we should not fall in the trap of letting our morale down. And I really appreciate the leadership of UNAIDS and the staff of dealing with the situation as it is. It's not easy, it's difficult, but we will get through. We have to show character. Character is accurately measured by one's reaction to life's disappointment. So when it's difficult, that's when you need character. You can also say when the going gets tough, the tough gets going. That's where we're going to go. And with all that, I would like to thank you all, because it's officially closing, I think. So, Your Excellencies, all speakers, chairs, activists, and all people who watched in countries, I'd like to thank you for your work and your commitment. Let us not stop here. Let us stand a chance we still all have by ending HIV/AIDS. Thank you very much.
Thank you very much, Ambassador. It is now my pleasure to invite us upstairs. Please don't go out, go upstairs so that we can mingle and chat a little bit. I'm sure you've had a very long day. Thank you very much.